foggy. Yes, and keep rubbing it. Well, how can I go and keep rubbing the uterus and do all these other things? You can't. So you need somebody to come help you. So you're going to be massaging the uterus. Somebody else is going to probably be helping to check the patient's vital signs. Somebody else is increasing the IV fluid rate. Usually those IV fluids have what in them? Pitocin. If they don't, we can add Pitocin in there. But if the patient is bleeding this much, our interventions need to happen very rapidly. We're not letting this go on for hours and hours and hours. Otherwise, your mom will pass away. So we need quick intervention. It's kind of like we need it to stop right away. And if it doesn't, we then progress with our interventions. So certainly we want to encourage breastfeeding. Now, if I have somebody who's hypotensive and in shock, I'm not going to have her breastfeed the baby, okay? Because it doesn't make sense. If that's not enough, I can't guarantee there's enough endogenous oxytocin to cause the bleeding to stop. This would be somebody who's at risk or maybe had a lot of blood loss with delivery. So what's normal blood loss with delivery? 250 to 500. There was a little video on Moodle, talks you through. So basically if we weigh pads, 1 gram is equal to 1 milliliter. So that gives us a good estimate for how much blood loss. And we want to quantify blood loss. That is nursing evidence-based practice. And we need to do a better job with that. We can't just eyeball the container and say, it looks about 350. Meanwhile, you have all these saturated red 4x4s and laps everywhere. The other thing is with this, breastfeeding's good, vital signs. Sometimes vital signs will not change even though she's hemorrhaging because we have that compensatory mechanism in moms. Because remember, they still have that extra volume that they were carrying with pregnancy. So some moms kind of tolerate that initial kind of drop in fluid well because of the extra volume, but it rapidly will start to decline. So again, we really want to watch that bleeding carefully. Clots are a bad thing. And so what can happen when there's a clot inside the uterus, because we haven't massaged the uterus, the clot gets trapped up in the uterus, and all this blood just keeps pooling and pooling and pooling and pooling behind the clot. And that's what often makes the fundus higher, because the uterus is filling up with blood. I have been in a postpartum hemorrhage a few times, and sometimes the patient's bleeding like blood's dripping on the floor. You're standing in blood. And then you're transfusing, and as fast as you're putting it in, it's kind of coming out. It's really a pretty scary situation. I heard feedback, somebody had a patient who got blood. That's Norton Women Children's. Somebody had a patient that got blood transfusion? Yes? No? Called out. We talked about you today, Katie. I will say it seems like there's always somebody getting transfused. Typically, you're not seeing transfusions until we get kind of below 8, below 7, in that range. So I was kind of curious how low that patient's hemoglobin was when they decided to transfuse her. The other thing is if you have a big drop and the patient's symptomatic. But generally, we try to treat the cause, which is usually, again, postpartum hemorrhage, and once it's resolved, we just give time for her to recover from that. You definitely want to keep her IV in. So let's say a patient has a history of postpartum hemorrhage. She delivers for you today. I'm going to leave that IV in. I'm not going to take it out even though it might, we're worried about hospital-acquired healthcare associated infections and whatnot, because I want to have that IV access, because if she hemorrhages, it's really hard to get an IV started. And then the medications, this is what has been my experience recently in terms of the order. So we usually start with Pitocin. If we don't get the desired response there, we go to misoprostol, which is Cytotec. We don't get the response there, then we go into these other drugs. So the first one, methyl ergonovine maleate, that is known as Methergin. The big contraindication for Methergin, and one of the side effects of Methergin, is elevated blood pressure. So we never give that to patients who have hypertension. So Methergin is PO or IM. So it is something that can be repeated. In other words, you might have a patient who's taking Methergin every 6 or 12 hours for maybe 24 hours or so, but it's not something that she would take for 6 weeks. It's only for a couple of, maybe a day or so, something like that. Whereas prostaglandin carboprost, that's Hemabate. It's a horrible drug. I have not heard anything from the clinical instructors about anybody getting Hemabate, which is good because it's really the last resort. It's the last thing we try for uterine atony. If it doesn't work, we are concerned about that the patient's going to need either a DNC or a hysterectomy. I also want to bring up uterine balloon tamponade, which is coming up. Okay, but Hemabate, it makes you have a fever and it makes you have horrible diarrhea. So as a nurse, whenever I give Hemabate, I usually have to pre-medicate my patient with Tylenol and Lomotil at the same time. But you're bleeding so much, you're hemorrhaging, and now I add fever and diarrhea on top. It's just horrible. And there's all kinds of complications if you have chronic disease that you can't take that drug. I'm not, but again, if we're at our last resort there for using it. If my patient's hemorrhaging, I often will put in a catheter. And the other reason I do this is if she has to go to the OR, the catheter's in. It's one less thing that I have to worry about if she does go to the OR. And then NPO if we think she's going to go to surgery. Depending on her oxygen level, we can put oxygen on her. They might do an ultrasound to look for retained products of conception. And then the other thing that has really helped in terms of uterine atony and how we treat it is the uterine balloon tamponade. And it's so funny because people used to call them Cook catheters, and now people are calling them Bakri catheters, Bakery or I say Bakri. I think it's the same thing. I think Cook is the manufacturer or something like that. But basically, it's really kind of cool. It's similar to a Foley catheter. It gets inserted, we inflate the balloon, and it's putting pressure up on from the inside of the uterus. It should be sterile because we don't want to put anything non-sterile up inside the uterus because all those blood vessels are wide open. You can kind of see here, I don't know if I'm a big fan of this particular picture here, but this is from the book. And so this is where you have the provider trying to compress the uterus kind of between the two hands. If there ever is a glove going up inside the vagina on a postpartum patient, it must be sterile. Must be sterile. And then if that patient has any type of manual removal of retained placenta or anything like that, the patient usually is on IV antibiotics and she'll have a longer length of stay. Because again, she's at really high risk of infection. So again, tamponade is fairly good because it's mechanical. You don't have to go to surgery. You get to keep your uterus, so if you want to have babies more, you can do that. If it doesn't work, we take you to surgery. And then ultimately, we might do some, any kind of laceration that is bleeding. We might evacuate the hematoma. But if we can't get the bleeding to stop, we'll do a hysterectomy and remove the uterus to save the patient's life. So I think you have to frame it that way. It's like the very last thing we would do is a hysterectomy. Some of our patients, though, if they have a known accreta, remember I mentioned accreta with the placenta, they tell the patient ahead of time, we're going to do this C-section, but we may have to do a hysterectomy right then and there. They're not going to send the patient to mother baby and see if she bleeds or not, and see how she does. They'll just go ahead and do a hysterectomy while they're on the table. So hysterectomy, if a patient gets a C-section with a hysterectomy, the blood loss is often greater than it would be just C-section. So you want to stay with the patient, keep them informed. It's pretty scary. Certainly I would want to get the baby back to nursery. Don't try and have somebody in the room like take care of the baby. We want to kind of clear everybody out of the room. And then the other thing is making sure that if you get through an episode where she passed a bunch of clots and is bleeding, we're going to continue to monitor more frequently. So in other words, your routine might be vital signs once a shift or every 8 hours or 12 hours. If I have somebody who had a hemorrhage, I'm going to do vital signs every 4 hours or every 2 hours. Or if I go in and look at her and she looks a little pale to me, I'm going to go ahead and do a fundal check. I'm going to go ahead and check her vital signs. I'm not just going to follow the protocol. So on to infections. With infections, chorioamnionitis, if it didn't manifest during the labor and it manifests postpartum, postpartum, we might call it a different name by endometritis. For our purposes, they are essentially the same thing. So it is an infection in the uterus or in the uterine lining. You're at risk of this if you had C-section, if you had prolonged premature rupture of membranes. So let's say I had a patient whose water broke at 34 weeks, but she didn't deliver until 38 weeks. She's at high risk of endometritis. If you had prolonged C-sections, if you had a lot of procedures, a lot of exams, and like every other infection, diabetes. Diabetes, high sugar just provides calories and glucose for pathogens. Patients who have endometritis have very foul-smelling lochia, and they have a very, very tender uterus. So you barely put your hand on the patient, and they are on fire. It's like, and fever. So this is another reason why it's important to monitor your patient's temperature. Now remember, what should postpartum moms be doing normally or expected? So I'm 3 days postpartum, I should be diaphoretic. I should be sweating off my extra volume because I don't need it. I get those night sweats. Oh my gosh, my nightgown, it's drenched. I'm peeing everywhere. Okay, that's different than you have somebody who is chilled, right? Their skin, it's warm and dry. So that would cue you in that something's not right. So endometritis would be uterine infection, wound infection. So where might you get a wound infection if you're postpartum? Incisions, lacerations, so vaginal. So if I have a patient at a 1st degree, 2nd degree, they had a episiotomy. So any of those wounds can show us signs of infection. So blasts from the past. Let me see if I can get a different marker. Let's see how this works. So if this is your incision, remember that the stages of wound healing, in the inflammatory phase, I would expect to see some slight erythema, edema, and warmth in that kind of early couple days of wound healing. So this is normal and expected versus something like this, where the erythema and edema is not uniform and it's larger than what it should be. And then if there's nasty purulent drainage, or if I see things like dehiscence or evisceration where stuff comes out of the incision, that would be a bad thing. It's often associated with infection. So how do we prevent infections? Again, hopefully prior to surgery we're doing a prophylactic dose of antibiotics, but very simple behaviors like making sure you have good hand hygiene, making sure you're not touching the, some people, they itch when the wounds are healing and they like to scratch. And if they've got dirty hands, you are bringing things really close to that incision. When you are doing perineal care, they have a little bottle, and moms will say, I don't need to do that at home, right? And the answer is, yeah, you do need to do that at home. Again, most of the time with incisions, the more superficial incisions will heal faster than the deeper ones. So in episiotomy, 1st degree, 2nd degree, it's going to heal faster than the C-section incision. And then the other thing in terms of prevention with infection, I would make sure my patient is changing her pad every time she goes to the bathroom. So you don't want the same pad on all day long. And making sure, again, there's not tight, restricted clothing up around the incision, because warmth and moisture around an incision is a bad thing. UTI, you guys know UTI. Symptoms of UTI, what are they? Frequency, urgency, burning, dysuria. So remember, hematuria, okay, is it really hematuria? Probably not. It's probably lochia that's in the patient's urine. So if I think the patient has a UTI, often, again, there's that sensation that I need to go, but I can't. It hurts really bad. The pain tends to be around the symphysis pubis. That pain is different than cramping or uterine cramping or pain. Uterine cramping or pain is dull and achy. Sometimes it's, again, it can be kind of front to back, but it kind of comes and goes. UTI, it's more sharp pain. Sometimes going to the bathroom makes it worse. Sometimes going to the bathroom makes it better. And then the other thing is UTI can rapidly progress into pyelonephritis. So we get flank pain, fever, very sick nausea, vomiting. We see that a lot in postpartum patients. So you may have a patient who goes home but then comes in through the ER and she's having nausea, vomiting, and fever, and so you as the ER nurse are having to kind of quickly assess for a lot of different things to try and figure out what's going on with the patient. And sometimes it gets so focused on the OB part that you forget about the kidneys, you know. So, with any type of infection, we are very aggressive in the postpartum patient. Now, the white blood cell count is elevated. That's a physiologic process. But I'm telling you, women die from infection, and it goes like that. So often these are patients who are hospitalized for a couple of days while we get IV antibiotics on board until we get the culture and sensitivity back. And then the other thing is, if you have a patient who's taking antibiotics, they need to take them as directed and finish the prescription 100%. Don't stop taking it because you're feeling better, because it'll come back with a vengeance. All right? It's not uncommon to be on multiple antibiotics because it can be that life-threatening and that quick. Sepsis in postpartum patients is a significant issue. All right, so this might be new. Some of those things you're familiar with. Yeah, I know what infections, UTI. So again, what's new to you is mastitis. Mastitis tends to be a particular infection that we see in a few weeks postpartum. It's not something that we generally see in the first few days. And the reason why is because it usually occurs after the milk has come in. It's more common to see in breastfeeding moms than bottle feeding moms because bottle feeding moms have suppressed lactation. I will say though that when moms switch from breast to bottle feeding, it's a high risk time for developing mastitis. So whenever we have women who want to stop breastfeeding, they need to do so gradually. Just kind of maybe substitute one feeding. You don't want to abruptly go from nursing your baby every 3 hours to not nursing your baby at all. That's a bad thing. So with mastitis, you're at high risk of it if you have cracked or bleeding nipples. Again, here's a diagram, but here's an actual picture. You see the redness there around the right breast. Very tender. There might be a hard red mass on one of the breasts. And here's the other thing. These are very sick women, very high fever. They feel awful. A lot of women think they have the flu, and it's actually mastitis. So how do you prevent it? Making sure that you have the baby changing position. You inspect the nipples. You're looking to make sure the baby has a good latch. We don't want the baby sucking on the tip of the nipple. That's a bad latch. They really need to open their mouth more wide. Because again, if they're just on the tip of the nipple, that's a lot of friction, and that's what causes cracked and bleeding nipples. A good supported bra, lots of hand hygiene. That's another thing that I have seen in moms. They sometimes just don't take care of themselves. They're so busy taking care of everyone else. And you'll ask moms, it's like, when's the last time you took a shower? 3 days ago. You know, are you changing your clothes? Are these the same clothes you had on for 3 days? That's a problem. You know, we need to remedy that. Whenever you have symptoms, you need to call the doctor right away. So early intervention. Some cases of mastitis can be treated with PO antibiotics, but a lot of times you have to actually be admitted for IV antibiotics. So again, early identification is really important. Bottle feeding moms generally don't get mastitis at delivery in that first week, but it's that transition. So if you're breastfeeding and you want to switch to bottle feeding, what you would do is taper your feedings off, usually getting rid of one of the feedings and put formula in its place. Most new moms get rid of one either at night or one during the day. Now, for me, I would rather breastfeed at night because it's way easier than trying to get a bottle and get it all ready, you know, but you eliminate kind of one feeding every couple of days. So you really want to try and taper your breastfeeding and give yourself about a week or so before you have completely stopped breastfeeding. In terms of medications, the medications that are given are perfectly fine to be given while you are breastfeeding. And that's another big common confusion point for nurses and patients. We want her to continue to breastfeed, and that is also very important. If she stops breastfeeding, it actually makes the pain worse. So this infection, even though it is here within the breast, there's no concern there about that infection passing on and making the baby sick. Okay? We're not going to cause the baby to get septic because mom has mastitis. It's better to empty the breast, take antibiotics, take analgesics. Certainly, again, if she's in pain, the letdown reflex is impaired. So she may notice some breastfeeding problems with mastitis. But we still want her to continue to breastfeed as much as she can from the affected breast. So engorgement tends to be a bilateral phenomenon. Mastitis is often an unilateral problem. So looking at this, I would focus in your review of engorgement and mastitis. I would not spend a lot of time on plugged duct just because I think it will confuse you a little bit. Notice with engorgement, mom does not have a temp. It's the entire breast. But in mastitis, it's a hardened specific lump and very high fever, and she feels like she has the flu. So we do not give antibiotics for engorgement. We definitely give antibiotics for mastitis. So I want to go back to engorgement just because I spoke really fast on Tuesday, so I just want to make sure everybody's kind of clear. So if you have engorgement, are we likely to see this on the first day? No. Colostrum, you usually don't get engorgement from colostrum. So it's more of an issue when your milk comes in, which is usually around day 3 or so. So if you have engorgement, you're going to express a very small amount, just enough to make the breast softer so the baby can grab onto it, that foremilk. And remember, the foremilk doesn't have a lot of calories, doesn't have a lot of fat, proteins in it. It's more for alleviating thirst, okay? And then you're going to nurse the baby. Everybody's okay with that? Now, here's what you do not want to do. After you nurse the baby, if you still feel the breasts are full, okay, you'll take analgesics, you'll wear a supportive bra, but you should not pump. Because pumping is only going to make the engorgement worse. All right? So engorgement, the breasts are full, they're so full, they're so tight, it's difficult for the baby to latch on. Now, what happens if I'm bottle feeding and I have engorgement? Again, don't use the pump to get rid of the engorgement because you'll just keep making more milk. So when you're bottle feeding and we want to suppress lactation, we usually bind the breast. So you might use ACE wrap, real tight sports bra. We want to avoid any stimulation of the breast whatsoever because, again, that's a signal to your body to make more milk. And I believe you talked about that in orientation. We don't give the pills anymore to drive breast milk because they cause strokes in moms. So, yeah. All right. Thromboembolic disease. So you are quite familiar with all of this. You have done it a gazillion times in med-surg. It is exactly the same. Postpartum women, clotting is usually good because we want you to not hemorrhage, but then you get too much because of the fluid changes that occur, and we see clots, so very high risk of DVT, but also risk of things like pulmonary embolism, MI, and stroke, okay? So prevention is key. One of the best things we can do is get people moving around. I'm guessing you're seeing SCDs a fair amount, and on your C-section patients in particular. Drinking lots of fluids, no massage of the legs, and we really don't want postpartum anybody, but we really should not have anybody smoking because that's going to aggravate clots. If a patient has a DVT, the leg is warm to the touch, swollen, and it's edematous compared to the other leg. And a DVT can dislodge and become a pulmonary embolus. So what are signs and symptoms of a pulmonary embolus?
Sudden onset of shortness of air.
Shortness of breath. What else? Chest pain. Oxygen levels drop. They often kind of feel, so sometimes when a postpartum patient has a pulmonary embolus, it's early recognition is key, but I will tell you, I've seen nurses who thought it was anaphylaxis. Okay? To me, anaphylaxis is more difficulty breathing, like your throat swelling shut. pulmonary embolus to me is more, my experience with pulmonary embolus is it kind of almost mimics an MI, but the pain's in a different place. There might be pain with breathing, but it can be very sudden, very sudden. So pulmonary embolus, again, kind of tricky to pick up on. It's not uncommon sometimes when we get a patient with a DVT that they'll go ahead and do a VQ scan to look for pulmonary embolus in the postpartum patient because she's at high risk of having that. If we have a patient that we're concerned about with coags, that might be on a heparin drip, you might still see the use of some low molecular weight heparins. And then Coumadin, again, Coumadin is falling out of favor. Coumadin has a lot of variability. People metabolize it differently. It's very difficult to adjust. Sometimes people are on too much Coumadin or not enough Coumadin. So we have some newer medications that we actually kind of use more than Coumadin now. They're more expensive. Coumadin is a good option if you have somebody who has limited resources because it's cheaper than things like Eliquis and some other things that we're using for anticoagulation. So again, just to kind of review, and this is kind of old school for you guys, and just to kind of, you can read that and it should be like, yeah, I'm good. I know that stuff. So, all right. So, postpartum mood disorders. Are you talking to your moms at the hospital about baby blues? Screening for postpartum depression? Yeah, I mean, hopefully somewhere somebody has mentioned something about that when they're doing discharge teaching with your moms. It really should be happening and I'm pretty sure it is. Some of our facilities also call moms, so you might be at the desk and there's somebody assigned to do follow-up calls with moms a couple days after delivery or after discharge rather, to see how things are going. So when we talk about this, and I don't like the phrasing of this, adjustment reaction with depressed mood, good heavens, that just sounds horrible. I refer to it as baby blues. It's a pretty common phenomenon. Again, it starts earlier, and it can be from a day, but it could even last a couple of weeks, okay? So in baby blues, what happens is you kind of have the honeymoon period where everybody's there, you have lots of help, you've got lots of gifts, everybody brought food for you, and then they all left. And then you're there with the baby, and it's like the honeymoon's over, and it's like, oh my gosh, I'm now a parent. I'm supposed to know what to do with this little person whose fingers and toes, and I just don't know what I'm doing. And I'm really overwhelmed. Oh, and by the way, I am bleeding so much, and I'm leaking everywhere. My eyes, my breasts, my vagina, it's just a hot mess. And so women get very overwhelmed. They are also not used to having to wake up every 3 to 4 hours. It's one thing to have to do that for a day or two, but after about 6 or 7 days of having to wake up every 3 to 4 hours, it makes one cranky and irritable. Hence the reason for this. So women will cry, they'll throw dishes, they'll get really upset. But they are predominantly happy, and in the baby blues, they can still take care of themselves, and they can still take care of the baby. And that's really what they need to focus on. We see it in people who have control issues. They want to control everything, and they want to give the appearance of being the perfect mother out of the gate. And it just doesn't happen. It's not realistic. So in this situation, it's not related to any type of stressor or psychiatric history. Generally, what these folks need is some extra support, not people telling them what to do. You know, you really should cover the baby more. Oh, you're feeding the baby too much. Have you tried sitting, grandparents really love to give a lot of advice, and you kind of need to just have them go away sometimes. But they need to rest, they need to eat, they need to drink. And so really the only thing that mom's doing is taking care of herself and the baby, getting a shower. It usually gets better. So it's a temporary kind of down in the dumps, sad, irritable phase. Unfortunately, what a lot of women think when they're going through that is that they have postpartum depression. And there's a lot more press now in media, good and bad, about postpartum depression. So look at my statistics, 4.5 to 28. That's a pretty good range of postpartum women. And I think the idea is what distinguishes baby blues from postpartum depression. This is far more severe. It lasts longer. and mom cannot take care of herself or the baby, okay? It usually happens a little bit later. It's not in the first week after delivery. And it can actually happen anytime during the first year postpartum. And so a lot of it we think has to do with role transition, adapting to being a parent, being responsible for another person, and a lot of hormone adjustment too, getting back to those kind of pre-pregnancy hormone levels. So we want to screen for in both the pediatrician and OB offices. So one example is the Edinburgh postnatal depression screen, which is called EPDS. There are some people who really do not like the Edinburgh. They think it's outdated. There's some newer studies using the Edinburgh, and they don't think it's holding up to time. And I think it's how women, depending on their age, describe their depressive symptoms. So you might see some other tools that are used to assess for depression. The key is that some type of tool is used. We can't just say, are you feeling depressed? Because there's a lot more to depression than are you feeling depressed. So we want to know about things like, are you feeling overwhelmed? Are you feeling that you're not caring for yourself? Have you had any thoughts of harming yourself or harming the baby? Do you feel like you're able to get up out of bed? Again, there's a lot of kind of everyday activities that cue us in that depression could be a problem for this patient. Safety's a priority. If you have a patient that says statements like, my daughter would be better off without me, it doesn't matter if I'm here or not, my husband can take care of the kids, that's a red flag for you as a nurse. And so we often need to take action, and I think, again, early intervention and frequent intervention, in some cases these folks will need to have crisis intervention and possibly inpatient care. We do treat women with antidepressants, so SSRIs, selective serotonin reuptake inhibitors. I hope you all know what those are. Okay. And then SNRIs, selective norepinephrine reuptake inhibitors. Those seem to be the ones that I see OBs prescribing. Now, I have some opinions about OBs prescribing antidepressants. It's not a good one. I think, to me, if you need help with your mental health, you need to go to the experts on mental health. And if you need help with OB, you go to the experts on OB. That said, I think sometimes folks don't realize that those antidepressants take some time. You know, they think, well, I took a pain pill, my pain went away right away, so how come when I took the Zoloft, it doesn't feel better right away? It's gonna take some time, and you probably recall from pharm that sometimes the risk of suicide actually increases when we first start taking those antidepressants because they have the energy to act out what they're thinking about doing. So they really need close monitoring. There's a lot of side effects with antidepressants. In some cases, depending on what medication the patient's on, they will have her stop lactating. Here locally, and I don't know what I think about this, but we've had some obstetricians who basically told patients to stop breastfeeding and see if that would help their depression. And I don't know if that was good advice or not. So the patient perceived it to be so because they felt better, because they weren't tied to breastfeeding, they were on antidepressants, and other people fed and helped take care of them. It's what allowed the patient to do more self-care. But I think that raised a red flag for me as a nurse. And then in the book, it talks about prevention strategies for postpartum depression. It's making sure, again, kind of preparing and being anticipatory that you're gonna have some good days and some bad days as a new mom, as a new parent. We're not experts out of the gate, we make mistakes. Your baby is not gonna be harmed because you accidentally left them asleep on the little play pad and the dog came up and slept next to them. They're not gonna have allergies the rest of their lives because the doggy is sleeping in the bed with them. We do make mistakes. The big thing is you just don't wanna make fatal mistakes, like the person who started their car, that was so sad, with the dad and the 2 kids who passed away from carbon monoxide poisoning this week. It's horrible. Warming up their car in the garage with the garage door shut. So it's that kind of stuff. Babies need to be in car seats. Anytime a baby's in a car, baby needs to be in a car seat. You don't want somebody holding the baby in the car. A lot of new moms like to take or parents take their kids out in the car because they won't go to sleep. Well, it's too much trouble to put them in the car seat, so I'm just gonna hold them in my arms while we drive around the neighborhood. That's a bad thing. So postpartum psychosis, unfortunately, this gets a ton of press. It is very traumatic and very upsetting, but it is very rare, okay? With psychosis, women will hear voices, they hallucinate. It'll say things like, God told me to kill my children, or my children need to be in heaven. It's the horrible things where people drive into the pond with all of their kids in the car and stuff. It's just really, really unusual behavior. We do see this with patients who've had previous history of some type of psychiatric illness. I know we had an experience once where a patient came in and she seemed like she had altered mental status, and at first we thought it was a stroke. So again, quick evaluation, turned out everything there was fine, and it actually turned out to be postpartum psychosis. So it was really kind of a difficult thing, but safety's the key thing. We want to make sure she doesn't hurt herself, hurt her baby or children. And then, again, pretty intensive treatment needed for postpartum psychosis. I think what I would suggest for you is to reassure patients that what they're experiencing is not this. It's not because you're sad, because you're having a really hard time, and you're having maybe postpartum depression, but it's not this. The other thing that we're seeing more things about is postpartum anxiety. And I think, again, it's moms who are not sleeping. They're kind of running 500 miles an hour constantly. They're very worried. They're obsessively worrying about things in their baby. What about they'll come to the pediatrician office repeatedly, and that's due to postpartum anxiety. And I think that's one of the reasons why you're hearing a lot of fussiness about the U.S. and what we do in terms of support at the time of delivery, that if we did a better job with kind of the first few months after delivery, that would help alleviate a lot of these concerns. So now let's talk about dads and partners. They actually also will go through and be at risk of emotional distress. So being a dad, being a new parent, it is very overwhelming. You have to think about some of our patients. So if you have a lesbian couple, one of the things that is very distressing, you'll hear questions like, well, who's the mother and who's the father? Well, that's not really an appropriate question. You have two moms. It's better if we look at who's the parent, who's the parent of this child. When we do different things in terms of dads and parents and partners, we downplay them. A lot of times partners feel like they can't do anything right. It's like, I can't change the diaper right, I can't feed the baby right. I work all day and I come home and right away, and it's like, I just got home, I can't do and so they don't know what to do. So again, as nurses, not only do we need to focus on mom and baby, but the family unit. So we need to think about the entire family and ask about the whole family in their transition. And again, give various strategies. It's not uncommon for men to sometimes feel angry and frustrated because men want to fix things. And sometimes with postpartum, there's not a lot to fix. It's kind of getting through that transition and adapting to what is now the new regular routine in your household. The other big thing with dads and partners, they can sometimes get overwhelmed and they're very concerned about money, and moms perceive that as being very materialistic. But it's the provider role and making sure that everything, it's like, here's the things I have control over and I can take care of. So that's why I'm asking, how much is daycare? Have you put the baby on health insurance? How much are diapers again? That seems really high, but that can cause some distress in the household. We sometimes see with dads and partners that one of the coping mechanisms that men sometimes use during this time is they use drugs and alcohol. So we want to watch for that. There's a phenomenon that men can actually have postpartum depression, and partners can have postpartum depression even though they're not the person who bore the child. And it has to do with, again, just feeling very overwhelmed during that transitory time. You think about it, you have this new little person, and you're not really sure you're doing the right thing, and you're scared, and you want to make sure you're taking care of your baby and your family. Men can sometimes be anger and aggressive. Sometimes we also see, sadly, relationships break up during this time. So if you have kind of a bumpy marriage, or you have some issues within marriage, this initial postpartum time can be really challenging. Some men, partners, they actually cheat. They get relationships with other people because they're trying to cope with their frustration and sadness and things like that. So it's not always a happy time. I think people think postpartum is a great, gosh, you got to be home for 12 weeks? Isn't that great? Good for you. That's really, it's not like 12 weeks at, the Bahamas. It's 12 weeks of really kind of adjusting and adapting